Okay, so we can start. It's now YouTube live. So I just sharing my presentation and then I will take give the mic to the Sarah. I hope my screen is visible, right? I am audible. Hello.
Yes, you are.
Okay. So dear friends, very good evening and welcome you all once more in our one more series of the international webinar series of the AACCI. And you all know AACCI is known for the its association for the adolescent and childcare in India, with its four pillars, that is the teachers, parents, grandparents, and children, and of course youth. We are dealing mainly with our holistic healthcare of the our urban based population with the help of the our 250 plus volunteers across the our India, and now we also having a different volunteers across the globe also. Our mission is to holistic health in the children and adolescent and young adult by promotion of the healthy lifestyle and prevention of the lifestyle associated disease. And from last year, we had already started very interesting webinar series of the our international forum with the help of the our international volunteers, and Dr. Sarin is one of the very pioneer for that thing, and we having a one more series with him today. It's my privilege to introduce today's speaker. Our one eminent speaker is the Dr. Sarah Pollick. She is second year developmental behavioral pediatrics and fellow at the Michigan. She completed her BA in the psychology from the Middlebury College, completed the medical school at the Michigan State University College of the Human Medicine, and pediatric residency at the University of the Michigan. She is the recipient of the James Mellon Simpson's MD Resident Initiative Awards, and her research interests including the autism and the spectrum disorder and hearing loss. Our today, our second speaker is our very well-known Dr. Neelkamal Soares, board certified developmental and behavioral pediatrics, completed her MBBS University of the Mumbai Lokmanya Tilak Municipal Medical College, residency in pediatrics from the University of the Illinois Chicago, and fellowship in the developmental behavioral pediatrics from the University of the Maryland Baltimore. Currently, he is the adjunct professor of the University of the Michigan Medical School and developmental and behavioral pediatricians in University Hospital Cleveland, OH. He is also the telehealth pediatric physician at Upper Peninsula Health System and consultant developmental and behavioral pediatrician at the Browser Methodist Hospital. In medical advisory board member of the Linus Biotechnology and Michigan Autism Council member also. So without wasting much time, I handing over the mic to the both the speaker to start the today's presentation. Thank you.
Wonderful. Thank you so much for having us. Are great. So we're very excited to talk to you today about torch infections and their developmental outcomes. I have no disclosures to report. And Dr. Soares, as mentioned in his bio, is on the medical advisory board for the Linus Biotechnology, and that has no conflict related to today's content. To review our objectives for today, we're hoping that after this presentation, you'll understand the role of the agents in the pathophysiology of fetal injury and some associated maternal factors that should be considered in these cases. Secondly, to be familiar with the clinical presentation and outcomes of torch infections. And lastly, to be able to articulate the role of a general pediatrician as well as other subspecialists in the management and care of patients with these conditions. So TORCH is an acronym that stands for the following pathogens. The first is toxoplasma. Second is this other category, which for the sake of time for today's presentation, we won't go into great detail, but we'll just list some of the main conditions that are kind of categorized in that and some resources for further review. R is for rubella, C for cytomegalovirus, and H for herpes simplex virus. These TORCH pathogens are commonly taught in our medical training as they are unique in that they can be passed vertically, meaning from mother to developing fetus. But there's a few ways that this can happen. The first, of course, being passage in utero through the placenta itself. Secondly, an infant may have been exposed during the birthing process while traveling through the birth canal. And lastly, postnatal passage through any bodily fluids where the virus or other pathogen could transmit from mom to baby, such as through breast milk or saliva. And so why do we really care about TORCH infections? We know that there are some neurodevelopmental sequelae that we need to be considering for infants, but really the spectrum of what that presentation looks like can be quite wide. We may have some clinical suspicion that a congenital infection might be present because the mom during her pregnancy may have certain symptoms, or during our routine monitoring may find some abnormal imaging on fetal ultrasound or other testing. We may also have concerns that once born, a newborn may be presenting with symptoms of an infection that may raise concern for a congenital infection. But we know that oftentimes babies are born and don't have any symptoms at all, but may develop sequelae later on that may raise concern that there might have been a congenital infection that we just didn't pick up at that time. There are several maternal factors to consider when thinking about these infections. The first being, if a mom has had this infection for the first time, there's increased risk of transmission to the developing fetus. We also know that the disease burden, or how much of the virus or parasite or spirochete that is circulating in the mother's bloodstream can impact how likely it is to transmit to the developing fetus. So again, the higher the infection burden, the higher the likelihood of transmitting. There's also been research that's shown that certain viral strains or serotypes that the mother has been exposed to is more likely to transmit. And the timing within the pregnancy itself. If earlier in the gestational trimesters, the more likely this is to impact the central nervous system and other organs, as we know, as part of our embryogenesis. And so if the developing fetus has been exposed earlier on, there's a higher likelihood of increased disease severity. And then, of course, this doesn't all happen in a vacuum. It's important to consider where the mother in that kind of before pregnancy and during her pregnancy is living, as we know that there are differing rates of incidence and prevalence of these pathogens in various regions or countries around the world. And so while we normally present and talk about what we kind of know in the United States, we're hoping that we'll also mention today of relevance in India as well. And so I just really liked this graphic, just again, kind of depicting as we're going through the gestational period, the association between kind of where disease severity is to be highest earlier on, and then transmission as the pregnancy goes on. There's a few mechanisms that we like to highlight of how these pathogens can actually cause injury to the fetus. The first is that the pathogen can cause injury to the placenta, which we know is so important in passing nutrients that is needed, and that can impact the developing organs. Secondly, once the pathogen has transferred into fetal tissue. As that is replicating in those cells, that can disrupt development. And lastly, the mom, as she's been exposed and is mounting an immune response, cytokines and inflammation, all of that can also disrupt cell replication, lead to cell death, and can even make some epigenetic changes that we see later on. And I will now pass it over to Dr. Soares.
So, one of the things, as Dr. Pollick mentioned about prevalence, a lot of our studies, epidemiological studies, happen in the United States, but TORCH is present all around the world. And part of the difficulty in estimating prevalence is that many of the infections are asymptomatic, so the patient doesn't necessarily seek out clinical care. And even then, there might be other confounding factors. Usually, the diagnosis is made on serological evidence, but there's no standard TORCH panel or a schedule or a routine to have all pregnant women screened. There are some which are considered high risk who get screened with challenging obstetric history or actual symptoms of the infectious contact. Next slide. So any of these numbers that I'm about to mention, consider that actually an underestimate of what's really going on because of the aforementioned reasons. So toxoplasma during pregnancy, this is in India data, and the references at the end of the slide deck. So it's between 20 to 44%. So that's pretty significant, a quarter to almost half of pregnancies. Rubella studies are limited. And I found this interesting because, I grew up in India, and so I got vaccinated with the measles vaccine, right? But when you come to the United States, then they want to check and see whether you had the total MMR, which is the combination. And so I had to get the rubella shot because I had actually gotten immune from infection from mumps when I was a child. So, but again, rubella studies are limited, and whatever's out there, the range is about 10 to 30% in adolescents, and then about the same in reproductive age women. CMV, the seroprevalence of IgG, so again, just the IgG part is pretty high in India. And again, similarly, the seroprevalence for IgG, which is more of the chronic marker for herpes simplex, is much more than the acute marker, which is IgM, and is highest in the first trimester. And then there's no good studies for parvovirus in India, but the seroprevalence is estimated to be between 43 to 70%. Next slide. So I'll hand this back to Dr. Pollick so she can talk about, but go ahead, Sarah, sorry.
Oh, I was gonna say, next I just figured we'll touch on each individual pathogen in a little bit more detail, starting with toxoplasmosis. And so the picture here is what would be looking like if we're looking at it under the microscope. But just as a review, this is a protozoan parasite related to foodborne, zoonotic, and intrauterine infections. We commonly think of it being found in cat feces, soil, undercooked meats. So hence why we normally advise pregnant women to not change the kitty litter. And as Dr. Soares pointed out, really seroprevalence varies by nations. It's estimated about 7.5% of childbearing age women are positive. And we see about 400 to 4,000 infants with congenital toxoplasmosis born in the United States each year, with global incidence about 1.5 per 1,000 births, the highest being in the Latin American countries. Interestingly, toxoplasmosis is included in some universal newborn screening programs in various countries around the world, but is not in the United States, Canada, or the UK. Toxoplasmosis can present with first intracranial calcifications, which is seen in the image here as those kind of bright white spots seen throughout the brain parenchyma. The second is hydrocephalus, so building up a fluid in the brain, which can be seen here in the picture of the infant with quite the large head circumference. And then also chorioretinitis, which can lead to potentially progressive vision loss. And as seen here in the fundoscopic photo, the kind of key clue words that you may read is that these are exudative cotton ball areas, which are areas of focal, atrophic, and pigmented scars within the retina itself. We've bolded these three as these are the classic kind of triad that we may see in the presentation, but one or all may not be present. Other commonly seen things in this presentation include hepatosplenomegaly, petechiae, jaundice, lymphadenopathy, but 80 to 90% of infants present asymptomatic or with no symptoms at all. There reassuringly has been little to no evidence of increased risk of developmental or cognitive delay in those who receive treatment with that combination of medications. The most researched outcomes are related to eye findings, as there's pretty high rates, above the 70% of chorioretinitis in those who are not treated. But even in those who are, around a quarter may have this presentation as well. We do know that there are poor outcomes in cases that are with more severe neurologic manifestations, so things like hydrocephaly or encephalopathy. And so, again, thinking through which infants may be at higher risk for these outcomes later on based on some of their presenting symptoms. Next, we'll move on to the other category. And as I said, we're just going to briefly list some that are included with some resources that you can look up later at a later time. In the United States, again, congenital varicella or chickenpox is more rare, especially with vaccination. Parvovirus harder to also pick up since we don't screen for that during pregnancy as well. And then, of course, listeria, HIV, and Zika, which had been in the news fairly recently when the outbreak had occurred in South America. So next we'll move on to congenital rubella. This again is extremely rare in the United States, but is associated with quite high mortality rates and preterm birth. The treatment for congenital rubella is mainly supportive, but of course we know that the best is for preventative care. And so making sure that prior to pregnancy, women are vaccinated or have had a booster so that we can prevent this condition from occurring in the first place. I included here the eye, heart, ruby earrings, as that was one that I had used in medical school as part of my studying. But this relates to the common rubella presentation that's taught. The first being cataracts as the eye findings, or at least one of them. There's a few other we'll list here as well. Congenital heart defects, specifically patent ductus arteriosus. Sensorineural hearing loss being the earrings. And as I said, some retinopathy, glaucoma can also occur as eye findings, and microcephaly. With neurodevelopmental outcomes in rubella, there's low incidence of developmental delays and learning difficulties. The most common sequelae that is to know is the hearing loss in about 80% of cases, and then vision loss in about 25%. Next is congenital cytomegalovirus. This is the most common congenital infection in the United States. Right now, it's thought to be about 1 in 200 children born with congenital CMV each year. But of course, the exact incidence in the United States is unknown, as this is not universally screened for in pregnancy. However, there's many at both state and national levels within the United States that are advocating for such. It is the leading non-genetic cause of neonatal sensorineural hearing loss. There's been some research into why CMV itself is so likely to lead to sequelae in the developing fetus. The first is that the virus itself can replicate in fetal astrocytes, which leads to central nervous system injury. Secondly, that the virus can lead to a vasculopathy within the blood vessels of the placenta, leading to injury. And lastly, again, kind of mounting an immune response with the cytokines and inflammation, leading to central nervous system injury. Congenital cytomegalovirus presentation can first be petechiae, can be associated with late preterm birth. These babies tend to be symmetrically small for gestational age and have accompanying microcephaly. They may have this kind of blueberry muffin rash or kind of those, spots throughout. They may develop sensorineural hearing loss, and this can be present at birth or develop later on. They can also have intracranial calcifications, and in contrast with toxoplasmosis, these calcifications tend to occur around the periphery of the ventricles of the brain, as shown here, and chorioretinitis. These babies may be also with these neurologic findings, increased risk for seizures. But again, 85 to 90% of infants are born asymptomatic. And so it often takes a pretty astute clinician to pick up on some of these signs at birth. As we know, like sometimes petechiae can occur because of a traumatic birth, as the infant is traveling through the birth canal, or they may, with preterm birth, may also be found to have jaundice, so maybe easily missed. But again, some hospitals, either institutions or states, have implemented certain screening protocols if infants meet some of these presentations to consider getting testing such as easy as a urine sample in the baby within their hospitalization at birth. For neurodevelopmental outcomes in congenital CMV, about 80% have no long-term sequelae. But we do know, kind of similarly to some of the previous pathogens we talked about, that there are poor outcomes associated with microcephaly or intracranial findings. But more severe presentations occur in about 1 to 5% of cases. And those that do have severe presentations are at increased risk for spastic quadriplegic cerebral palsy. They may also have low tone due to a vasculopathy in an area of the brain next to the basal ganglia. And they are also at risk of vestibular disturbances and gross motor delay, so seeing some impact on future balance. We also know that with sensorineural hearing loss can also come delays in speech and language, and that the hearing loss itself can really vary in its presentation, being either at birth, later on, may happen in one or both ears, and can occur kind of suddenly or maybe more gradual over time. There's been also some research around increased risk of attention deficit hyperactivity disorder and executive functioning deficits, along with autism spectrum disorder, which is actually an area of research of my research mentor, Dr. Pesh, within the University of Michigan Department of Developmental Behavioral Pediatrics. And so, again, I think more to come in this area. And why many providers have been advocating for thinking about institutional policies about early screening is that unlike many of the pathogens we've talked about previously, CMV has the potential for a treatment with an antiviral medication, valganciclovir. And the use of this medication has been associated with improved hearing and developmental outcomes at age 2 in those who were symptomatic. And ideally, the timing of when that valganciclovir is administered in symptomatic cases is under the 21 days of age. And so, of course, you've had to have identified this condition and then started treatment in a timely manner to get the best outcomes. So again, why many advocate for early intervention as possible. And so this was a diagram from one of the papers from Dr. Pesh that again kind of went through if there's a suspected case, really the timing of it, if it is found positive, once you've confirmed the diagnosis, who would be the kind of next steps of additional evaluation and subsequent treatment. And so thinking about an ophthalmology exam, getting in with infectious disease to help with prescription and monitoring of valganciclovir use, getting beyond just the newborn hearing screen, testing for hearing, and then laboratory evaluation or cranial imaging as indicated. Of course, whether the infant is symptomatic or not is important. And so once we confirm this, if they are indeed symptomatic, then considering antiviral medications and dosing and monitoring of that, as well as long-term monitoring over time, including developmental surveillance and subspecialists in the future. So that was a lot on congenital CMV, but it's one that we know quite well in the U.S. So now we'll move on to congenital herpes. Herpes simplex virus, the true congenital infection is quite rare, but we know that neonatal and perinatal infections are much more common. And this is spread via skin-to-skin contact with any sores or saliva that has been present with HSV. Its presentation can have a vesicular rash, as seen here in the photos on the abdomen and around the umbilical cord. Can have ophthalmologic presentations, as well as impacting the central nervous system. This is, of course, one that we always think of as in fever of the newborn for a meningitis type picture. And so similarly, as other infants with meningitis, neurodevelopmental outcomes tend to include things like vision loss, severe gross motor delay, and other neurologic impairments. So now that we've talked about each of the individual pathogens, we thought we'd just end this segment on some of the emerging research of the risk of autism spectrum disorder with many of these congenital infections. The exact etiology is not quite known, but it's been proposed that this is due to aberrant synaptic pruning by fetal microglia in the setting of infection that may be risked, which may be linked to this disorder. When looking at CMV in particular, there's was a study that looked at newborn dried blood spots and found the prevalence as high as 5% in children with autism. And so again, I think this is an area where we'll see much more research in the future, but something to consider when advising parents of those who have been identified as having a congenital infection, that this is something that may be on your radar as you as the child ages and on developmental screenings. And so now we'll pivot and try to make, again, I think what we heard from you all is that we want to also present on the relevance to you in your day-to-day life. And so thinking about the role of the pediatrician and other specialists in the care of these newborns. First and foremost, if we haven't said already, we feel like this is something that we should be considering in the differential diagnosis for patients who may have developmental differences or signs at birth. And then considering ongoing surveillance over time as many are born asymptomatic, but may develop sequelae later on. And so then thinking back of, when this is present, maybe we should be thinking about in that perinatal and postnatal period, what may have been, contributing to the later presentation. Being DBPs ourselves, we hope that you feel like you can easily reach out to us if any concerns arise on developmental screeners at your routine well visits, or other subspecialists who can do kind of deeper developmental or neuropsychological evaluations in the future. And again, the earlier the identification, the earlier that you can get them into appropriate services, because we know that that is also important for outcomes later on. And then really the pediatrician should be that medical home for the patient, and that they can help coordinate care with the various subspecialists that may be involved based on the sequelae that the infant or child has. So whether that be infectious disease or your audiology or ophthalmology. And so we created this table to hopefully, again, make it a little easier to think about some of the clinical concerns that may arise, some developmental surveillance to consider, and then maybe other subspecialists or referrals that might be prudent based on the age of the child. So the first here being kind of birth to the 1 month time period. We know that infants may have some signs at birth, but also, poor tone, feeding difficulties, and that might be a sign that we should be considering laboratory studies or neuroimaging, as well as, getting initial data points and tracking weight and growth over time. Thinking about pediatric ophthalmology and audiology referrals, even if the newborn has passed their hearing screen, as we know that they can develop hearing loss later on. Of course, getting our infectious disease specialist involved, and neurology if there's any CNS involvement. When we then move on to the 1 month to 1 year time point, many of the clinical concerns may still be the same, but there may be more persistent hypotonia and or spasticity, as well as sleep difficulties. And so again, considering to follow that trend of growth trajectories and routine developmental screening at your well visits, starting from 2 months on. I think this is also a good time to set up expectations for families of what future care with annual eye exams and hearing screening, as this may be more frequent than in kind of typical children, especially for CMV. They usually recommend between 3 to 6 months until age 3, and then annually until age 6. And then, as we said, refer to DBP or other subspecialists by at least 12 months when there's any delays present, and also referring to early intervention services. Moving on to the kind of toddler and early elementary age. Again, many of the clinical concerns may be the same, but here we may be seeing, now that they're enrolled in kindergarten and on, of learning difficulties, some behavior problems, and balance and motility as they are now on the move. And so for surveillance, again, monitoring growth and developmental screeners, especially autism, beginning around that 18 to 24 month time period. And again, I think relating to the balance and mobility needs, maybe considering vestibular testing, our PM&R colleagues, as well as physical therapy if any balance or tone concerns arise. And not only early intervention, but then thinking about school-based supports as from like 3 on, if the child would be eligible for those as well. And then I think some of the unique points from the 6 to 18 years is also thinking about some difficulties with self-care, as we're expecting, children and adolescents to become more independent. And so making sure we're screening for those factors as well. Similar surveillance, but at this time, maybe also considering rating scales for ADHD. Given that they're 6 and older, perhaps considering neuropsychological testing for cognitive or learning concerns, as we know that IQ is more easily tested at those ages. And again, thinking about school-based supports, but also what then happens after they've graduated, secondary, into education and transition planning for either school or employment or other needs. And if any care needs to be transferred from pediatric care providers to adult care providers. So, Soares.
So, as Dr. Pollock's been talking about, I didn't want anyone to get the impression that there are no guidelines for India. There are. In 2022, a group of experts came together under the auspices of the IEP, and they have flowcharts for the torch infections. And so if you all are not familiar with this, please get it. It's freely available online, and it would guide through sort of the similar types of things, right? What sort of information do you have? Have you confirmed the information? This mostly is relating around sort of maternal perinatal type health. And then, of course, coming down to what are some of the symptoms, asymptomatic or not. And when I looked at this, it's more of a acute symptomatic treatment as you look at this. And really what Dr. Pollick is trying to emphasize, and what we hope is that you look at it as a longitudinal thing, just because you can control infections and the immediate sequelae and anything that's revolving around, severe symptoms at birth or in the soon neonatal period, there are always going to be long-term sequelae that you need to keep an eye on. And that can only happen through serial developmental surveillance through the primary pediatrician, quick referrals to specialists as needed, both for diagnostics of comorbid conditions, but also for sort of guidance on management. And then, of course, therapies, whether it be physical therapy, occupational therapy, speech therapy, developmental support, special education, etc. So it's the acute, obviously, for infection treating, which is well known, and you all know how to do it, but I think connecting with your bigger network of specialists is going to be important as well for long-term chronic sequelae, because those can be very impacting, particularly in childhood and adolescence. Next slide. The other things that I want you all to be aware of is that, in the US, we have this concept of interdisciplinary a lot, where it's like no one specialist, not a developmentalist, not a neurologist, not a speech therapist. No one can handle it themselves. So really collaborating with the team, and the guidelines are really good about, what do you do in the postpartum and immediate. But really, we're talking about the dyad here. You've got to support the family as well as the child. So really working with the parental units, making sure that they understand. Because one of the risks is, you have to remember, just because you have that one child with a congenital torch infection does not mean that the risk factors don't exist in the family. And there has to be guidance about this for future pregnancies, right? So if there's exposure to a pathogen in the environment, right? And Dr. Pesh talks about this a lot, is that, people talk about, animals and secretions and things like that. You've got to be mindful that if you are exposed and you have a child, and let's say the child received treatment and they happen to be doing better, you've got to really be mindful that there's no exposure to the next pregnancy, because this is not a one and done. It's different than genetics, obviously, but mitigating preventative measures, making sure you have treatment options, and then obviously, talking to complications, right? Explaining that some complications are immediate and obvious, like seizures and things that are cataracts and hearing loss, which can be. But the longer term complications include cognitive impairment, risk for autism spectrum disorder, learning disabilities, etc. Those things also have to be explained. Next slide. And the team, as she had mentioned too, but I wanted to reiterate, is a lot of people. It's more than just physicians, right? It's physicians, it's nurses, social workers, behavioral health specialists, nutritionists, audiologists are so critical, particularly when hearing impairment comes into play, because it is really hard to do standard conventional audiology in children. And so audiologists have techniques and strategies to use different ways other than just with headphones and a soundboard. And then obviously looking beyond the specialist for rehabilitation, right? Physical med rehab, but also therapists. Next slide. I'll hand this back to Dr. Pollick because she's done some great homework about some of the global resources.
Yes, so we also wanted to provide some links or organizations that can be both for providers, but also some patient-facing resources. So the first being the Center for Disease Control and Prevention, the CDC in the U.S., as well as the World Health Organization. And there's also many that are kind of pathogen specific, such as the Congenital CMV Association or the Toxoplasmosis Research Institute, that you can also find additional research updates or other kind of emerging information. Also then thinking about where you can direct patients and their families. Again, things like the March of Dimes, as well as the National Organization for Rare Disorders, which is includes but is not limited to torch infections. And then two, thinking about resources based on the sequelae that the patient may have. And so, for example, we have a great organization in the U.S., Hands and Voices, which is a parent-led organization for children who are deaf and hard of hearing, as well as those for, the Epilepsy Foundation or National Federation for the Blind. And so, again, trying to tailor some of your, guidance for families kind of based on the child who's in front of you. And so if we have a little bit of time, I'll kind of briefly fly through this one. We just thought we'd provide a case example. This is a 4-year-old who had a history of expressive language delay and unilateral profound hearing loss, who was referred to DBP for disruptive behavior. He's described as clumsy and has difficulty writing, using scissors, and fastening buttons. He has a particular interest in vacuums, has trouble making friends, and dislikes haircuts and baths. As part of a cochlear implant evaluation, he's had brain imaging with trace calcifications and small cysts. On your evaluation, he's diagnosed with developmental coordination disorder and autism spectrum disorder. And so we thought this was just a good case example to be thinking about, like, what congenital infection might be at play here and what might be some next steps. And so for the answer, we have congenital cytomegalovirus. I just included here because developmental coordination disorder, or also known as dyspraxia, wasn't a diagnosis I had known much about prior to fellowship, and it is a DSM-5 condition where there are delayed motor skills below what's expected of the child's age. They might be described as kind of clumsy or have difficulty with kind of basic ADLs, and it needs to be functionally impairing in the early developmental period and is not better explained by another condition such as intellectual disability or CP or another neurologic condition. And so some things we think that would be prudent to think about as next steps would be confirmatory testing with use of a banked dried blood spot card if available. In the US, this really varies based on which state you're in, if they do this at all, or also for how long that card is stored, but also other testing like PCR. Of course, ophthalmology referral if this has not been done, as well as continued care with their audiologist, and maybe considering a vestibular evaluation. As we know, children with CMV can have balance issues. An infectious disease referral, as well as DCD and autism-related services that would match kind of the family's goals and help, again, promote skill building. and thinking through a special education evaluation as well. This child is, was 4, and so thinking if they had had early intervention services through age 3 and had made that transition over, also making sure that they're in the correct classroom placement with access to things like, an F&M system if they need for their cochlear implant to be able to hear the teacher, or having a teacher of the deaf. So just some other considerations to think about. So again, we're including just some of the resources that we used in this presentation. And I will just put up, we will be sharing a link because we'd love to hear feedback of your thoughts on today's presentation, and we're happy to take any questions.
Thank you, Sarah and Sarin, Dr. Neil. It's really a great, very short and sweet presentation of the combination of the all the torch infection and how it is impact in the development of the each and every child who develops such type of the problem. Only thing you had given a broad spectrum idea about the there is a start related with the autism spectrum disorder. Is there any specific disorder other than that autism spectrum that is correlated with a specific disease that will be included in the torch?
So I go ahead, Sarah, but I would just say
first.
a couple of things is intellectual impairment, intellectual disability can be associated with several of the torts. So we always recommend, other than looking at autism, you also want to look at cognitive functioning by itself, because autism also cannot be easily diagnosed unless you understand clearly what the intellectual functioning is. So if somebody wants to do an autism test on a child, we always recommend making sure a psychologist or the school or somebody else is doing IQ testing and adaptive testing, because if you don't have that, it's hard to tease out which part is intellectual, which part is autism, and which part is both. So I would say, like as Sarah said, autism can be associated with several, but I would also add intellectual disability without autism, just straight ID would be one. Sarah, go ahead with other things you were thinking.
That was the first one I was thinking. And 2, that is so important to consider that the child has at least a cognitive level of 12 months or older to even consider doing that testing in the first place. And so, making sure that you're not just looking at the chronological age of the child, but thinking actually, where are they developmentally, and is this testing even appropriate to do at this time, or do we need to wait and consider that in the future? But I think that was the main one I had.
Yeah, and Samir, the thing is with seizures also, right? The issue with a specific condition causing specific symptoms or specific things, it is very tricky because there are many examples in which there could be multiple infections going on or other things going on, right? So just because you have evidence of a torch infection does not mean that rules out a genetic etiology for something else. And we have seen that where people can have more than one thing. So I'm not saying do multiple tests at one time. Take care of the most obvious one first, but keep your mind open over time, particularly if there's strong family history or if there are symptoms that don't totally explain. So we've all often seen this concept called diagnostic overshadowing, where once a person, a doctor or a specialist, comes up with a single diagnosis, they try and fit everything into that box. And that's not always the case. There could be more than one thing. And what that does, it disadvantages the family, because now they're stuck in that box of everything this child has is only this disorder. And they may miss out opportunities for therapy or treatments for the second thing the child has, which wasn't delved into because everyone got hung up on this overshadowing. It's one thing, it can't be two things. Does that make sense?
Absolutely perfect. Second important thing, what I having a theory or the one idea, what I thinking related with the torch infection and the autism spectrum and other disability related, because there may be a chances of the sensory neuronal hearing loss also, that so that may be of the one of the associated thing that may lead to the problem related with the autism spectrum and that thing. So can that be a more related rather than some factor that what we are directly targeting to the infection rather than the effect of the infection that lead to this type of the etiology?
That's a good point. The one thing I'll point out though, Samir, is that if you've got sensory neural or conductive or any sort of hearing loss, and even if you have intellectual impairment, the one thing that's not going to be seriously impacted is nonverbal communication, right? So when a child who has suspected autism appears to have good nonverbal communication, eye contact, gestures, shrugging, pointing, shaking their head, waving, and things like that, and relatively good play or interest in others. So even if they are very impaired cognitively, they show a connection to the other person, wish to be with them, wish to show them something. Then you start saying, is this really autism? So you can have sensory neural hearing loss. I would say it doesn't necessarily lead to autism, because what happens is the sensory neural cause gives you many of the symptoms: not responding to name, language deficits, all those things. You can even have repetitive behavior, shaking your head, flapping your hand, but you will not have impairment in eye contact, gestures, play, sharing, and showing. So if you have sensory neural hearing loss and you're suspecting there's a secondary autism, it should meet all those nonverbal criteria. But then it becomes hard to say chicken or egg. You can't say one led to the other. I would say they were both happening in parallel, because the neuronal and the pruning got disrupted, and there was toxic effect on the nerves or whatever, but then one showed up slightly before the other. And there's a human nature to attribute, okay, this showed up and it led to this. But I think if the non-verbal is intact, then you stay just with the SNHL and you say, I don't believe the person meets criteria for autism because this is not met. Does that make sense?
Yes, yes, absolutely perfect. Means there is a definitely chance that sensory neural deafness may be a one of the associated factor, but it not be directly leading to the autism. What you are saying that because autism is specifically having a non-verbal communication is also not present, and that indicate that that's something different than what the sensory neuronal deafness do. That's
Yeah.
really a make a sense. Definitely, yes.
Are there any questions from the audience, either in the chat that you can see, or we can ask people to raise their hand and ask? That's fine. We have some time.
Yeah, yeah. So now we can open the forum to the question answer session for anybody who are joined today in the thing. You can just raise your hand up hand and directly unmute yourself and ask the question to the our respected faculty today. One more question from my side, Dr. Neil. Which are the infection that is coming more that is related with this type of the neurological defect? What you are seeing more? Is it the CMV or the is it will be rubella?
Sarah, you'll take that one. Which is most likely associated with the neurological outcomes?
I usually would say CCMB, and at least especially too with the prevalence and incidence that occurs, we're more likely then to see those outcomes as well. Dr. Soares, have you seen any different? That is the one that I think of the most with
Yeah.
neurodevelopmental outcomes.
Yeah, the other thing also, remember, in the US, I mean, we're seeing, because of vaccinations with measles, mumps, and rubella, MMR tends to be covered, so rubella is not as much of an issue. It might be different in India, but really CMV is a hidden sneaking up on you, because people forget how insidious it is, how it can be easily transmitted from, parent to infant, etc. And so I would also agree. It also comes very sneakily, unlike like sometimes with herpes and others. You can have probably obvious signs and symptoms in the parent. There where people are very familiar with the cold sores, herpes simplex, things like that. And then, with toxo and stuff, with zoonotic and other things. So I think CMV is the one I am most nervous about, and the one that I think we need the most education about.
Right. I think
And to the presentation that the kind of common stem that you may hear is that parent may have an older child. And so that preschooler that has then been exposed and likely bringing that home then shares with mom because mom has, kissed on the lips or has shared a utensil or a cup, and kind of unknowingly has, while pregnant, then, kind of exposed herself, and she may or may not develop those similar cold symptoms in pregnancy. And so, as Dr. Soares says, women tend to then, in retrospect, maybe say like, oh, maybe I felt a little bit of a sniffle or things, but that's just common in my household because we have a preschooler running around. And it's not until some of those neurodevelopmental sequelae start arising and people saying, where is this coming from? Should we be thinking about other, etiologies that may come up? And so again, thinking about, is this something that's commonly educated during pregnancies to consider the risk of?
Yeah, right. In India, basically now we having now enough time and exposure that we are now having a universally vaccinated with the MR, measles and rubella. So now it's also the same thing that related with that thing. In private, we are exclusively giving the only MMR, not even MR also. In government, they are giving the things is the MR 2 doses they are giving. So it will be the enough exposure of the rubella vaccination is there. So there is a least chances that what we are now also getting the rubella vaccination here, rubella diseases here also in India. So India, it is almost more than 20 years now we are giving the MR also. And in government schedule, it is more than 10 years now they are giving the MR.
So I guess then maybe real good education to pregnant women about congenital CMV precautions and things like that. That would be really good, helpful for your patients.
Right, right. Any more question from the any participants? You can directly unmute and directly ask the question to our faculty. So now I am directly again giving your link to giving the feedback to here. So we can conclude because it's 9 p.m. here. We have completed the almost 1 hour discussion regarding the same. So all are requested to click on this link and give your honest feedback regarding the today's presentation, and that will help us to improve the ourselves also. And if you are having any query, you can definitely write your query question into the chat box also. I am adding that our email address to you. You can directly ask in this email. We will ask to our faculty and we will come to back to for your answer.
So, Samir, we will look forward next month to another wonderful presentation with another one of our colleagues from Michigan. It will be around, developmental behavioral perspectives of encopresis and enuresis, focusing more on the behavioral and some of the strategies and things like that. And Dr. Felt is a true expert, and Dr. Burke will be on. So we'll be looking forward to our April session also.
Absolutely perfect. So my sincere thanks to the Dr. Neil Soren because he is really a key person doing so many international webinar series with the help of your other partners, and it's really excellent for me to also to connect you in repeatedly every month with the same time and same date what we are planning every second week of the every month, and it's really a great part that we are able to continue these things since 1 year regular basis now. So now it's a really a good initiative of the AACCI that is coming to what we are planned since 2021. But at the last, we are able to start it regularly in 2024. So thanks a lot, Dr. Neil. and Dr. Saraf for that excellent presentation today. And we will definitely look forward for next month also with same type of the presentation from the you all and the delegates really who enthusiastically hearing us in a regular basis. Thanks a lot. And our YouTube link will be circulated to the our own the group. I will share with you also. You can definitely circulate that to in your circle also. Thanks a lot once again. Thank you
Thank you.
and good night
Take
and
care.
good day.
Good day. Bye.
Good day.